Greetings, PsyQ community. This is Rachel Self with Otsuka Neuroscience Medical Affairs, joined by Dr. William Gilmer to discuss Mixicity in Depression. What is it, and why is it important for my practice? Dr. Gilmer is a clinical professor of psychiatry and behavioral sciences at the Northwestern University Feinberg School of Medicine, and he has been gracious enough to join us today to discuss this important topic on mixed features or mixicity in depression. Without further ado, Dr. Gilmer, please take it away.
Thank you, Dr. Self. Well, it is a pleasure to be here with you today, and I'm looking forward to this talk. The objectives of this talk are to review the history of mixed states, specifically within depression. We're going to focus on how that is conceptualized, the phenomenology of mixed states, and the various diagnostic considerations that go along with it. And particularly, we're going to highlight the clinical relevance of correctly identifying mixed states across the spectrum of depressions. We're also going to talk about the impact of mixicity on the course of illness and treatment outcome. We'll first start off with the history and a bit of a phenomenology lecture on what mixed states look like and how they're conceptualized. The modern history of mixed states starts in the late 19th century at the University of Heidelberg, where Kraepelin was the director of the psychiatric clinic and his colleague Weygand, and the two wrote about mixed states in 1899. Kraepelin later expanded upon that and included a complete chapter about mixed states within his classic 1921 textbook, Manic, Depressive Insanity. What I'd like you to do is notice how the slide is divided up, both on top and below the arrow. The top timeline is essentially the timeline of mixed states within Europe, where, frankly, the greatest developments have happened in the conceptualization of mixed states over the last century plus. The lower level is the history, much more recent, you'll notice, in the United States. And we'll talk about how those sort of evolved and where they're bringing us to this day. So we start back in 1899, 1920 with Kraepelin. The next real consideration of mixed states did not occur until ICD-9 in 1978. At this time, DSM-1, 2, and 3 were entirely silent on the concept of mixed states or mixed features. Approximately in the early 80s, there was a classification designated the Vienna Research Criteria for mixed states that really influenced the next couple decades and informed current conceptualizations of mixed states. Here in the United States, up until the time of DSM-4, the TR version, very little comment was made about mixed states. And even then, it was specifically only for mania. The one sole holdout, and we're very grateful, is to Hagop Pakiskel, who collaborated with many of the European thought leaders in the area of affective illness. And Hagop, for many years, has been writing about and studying depressive mixed states. And what I think is probably one of the quintessential papers from a clinical usefulness standpoint is a paper from 1996, where he gives a very clinically useful description of what a depressive mixed state looks like. It wasn't until here in the United States, until the very recent inclusion in 2013 within the DSM-5, that mixed features were finally added to both hypomania as well as mania and major depressive episodes. So in other words, it would be possible for a person to have mixed states identified as a component of their major depressive episode, whether that was bipolar or major depressive disorder. Concurrent with that, as you see on the top line, again, is this continuation of the evolution of mixed states right up until over the past decade, when much work has come out of the Bridge study, the Bridge 2 study, with leading researchers within Europe, really driving our conceptualization, our thinking about mixed states. Interestingly, many of them very highly influenced by the early work of Kraepelin 120 years earlier. There are a few other topics or a few other concepts that have arisen over the last decade or two, and those are concepts of irritable depressions, agitated depressions, activation syndrome, and trying to understand the role of anxiety or anxious psychic distress and aggressiveness and impulsivity. These all also have figured into our considerations about how mixed features are both identified and classified. So back to Kraepelin, 1921. This quote, which I think really captures the essence of mixed states, especially depressive mixed states, is from his 1921 textbook, where he said, "But then very often we meet temporarily with states which do not exactly correspond either to manic excitement or to depression, but represent a mixture of morbid symptoms of both forms of manic depressive insanity." And underneath that, you see a visual graphic, and this is reproduced directly from his 1921 textbook, where he attempted to visually demonstrate what a mixed state looks like. And he did so, very importantly, by separating out various components or dimensions of phenomenology that are oftentimes represented in what he called manic depressive insanity. And the translations from the original German to English were called intellect. And intellect really meant cognition, thought process, emotion, or we might also say affect today, and then volition. And volition included both a behavioral motoric component, as well as an aspect of goal-directed behaviors. And so to Kraepelin, these three dimensions were key to understanding the multitude of symptoms that can occur within someone with manic depressive insanity. And I want to hasten to note that he was not using the term manic depressive insanity or manic depressive illness to only refer to what we now call bipolar disorders, but he was really referring to a form of recurrent affective illness. It was a unitary theory of recurrent affective illness, and that regardless of whether a person had only recurrent depressive episodes or depressions and hypomanias or manias, they were all considered various permutations of manic depressive insanity. And this is really key to understanding the evolution of recurrent affective illnesses. Again, back to this graphic, you'll notice are three different lines. You have sort of the dashed line, almost dotted line for emotion or affect, and then the solid line, which is volition or motoric behavior. And what he attempts to represent here is how those three dimensions or those three lines, while they may somewhat fluctuate in sync or they may follow a somewhat similar course, they are not necessarily always lying upon one another. Therefore, it's possible that one domain may be actually elevated, another domain may be in a perfectly sort of normal range, and the other or third dimension actually may be suppressed or lowered. And that is essentially what a mixed state is. And the next slide now, what we'll see is how he divides those up. Again, these are our three domains or dimensions that of emotion, affect, volition, motoric activity, and thought process or cognition. And what you see initially here are what we tend to think of classically as the orthodox pure states. So a pure depression, emotion or affect is depressed or decreased, volition, goal-directed behavior is decreased, thought activity is decreased. In mania or hypomania, those three dimensions are all increased or activated. The one thing that Kraepelin was, again, he was a brilliant phenomenologist. Kraepelin goes into great detail, sort of subdividing these different dimensions, and notes that even within volition and activity, that you have both goal-directed behaviors, you have motoric activity. It's a degree of actual physical activation or deactivation. Similarly with thought, another corollary of thought, another offshoot of thought process is degree of alertness. And he notes also how either alertness may be increased or it may be decreased. And this is, I think, a remarkably useful way to think about mixed states, because they challenge us in terms of how we think about mood disorders. So in some regards, mood disorders are actually a misnomer, because they sort of artificially put the emphasis upon mood, emotion, or affect to put the other two dimensions in a much lower level of importance. And actually, there are some mood disorder specialists, thought leaders, who would actually propose that mood disorders could just very easily be considered disorders of motoric behavior, overactivity or suppressed activity, or that they're disorders of thought activity. Again, not necessarily always thought content, but the degree of thought activity. And what Kraepelin very importantly recognized early on is that these three dimensions are distinct from one another, yet they're equally important, and they together, the various permutations can create a myriad of different clinical presentations that represent a remarkable range of clinical presentations that are all potentially aspects of the same underlying illness. And so if we go on, we'll see what Kraepelin actually suggested. And these are actually the English translations from Kraepelin's 1921 textbook for these different mixed states. And what you see is that essentially the arrows are dysynchronized. They're not all going the same direction. Obviously, we think of euthymia, the arrows would be horizontal or on neither going up or down. But in mixed states, which are frankly very common, you actually can see the multitude of these things. And this really gets at the essence of what a mixed state is. So back to Kraepelin, 1921 textbook. You can read these first two quotes. These come right from his chapter on mixed states. But he notes that these mixed states, that the phenomena sort of fluctuate, and they don't always disappear or appear on the same timeline. That is essentially what his graphic was representing. And noted that some of these morbid symptoms kind of vanish more quickly or more slowly than others, and that it's a highly protean variable state. These are not static states. And even though we sometimes refer to mixed episodes, the reality is that some people with mixed symptoms may fluctuate in and out of multitude of states within a 24-hour period. Let's go down to the bottom quote now, and this one coming right from DSM-5, the Glossary of Technical Terms from 2013. Whereas these concurrent mixed symptoms are relatively simultaneous, they may also occur closely juxtaposed in time as a waxing and waning of individual symptoms of the opposite pole. That is taken directly from Kraepelin, 1921. And I think it goes to really demonstrate that these are not new concepts, even though the American Psychiatric Association, its DSM 5, was very late to the stage in terms of acknowledging mixed states and talking about what they are. Is a concept that really evolves out of early conceptualizations that have existed for over 100 years. And this very quickly is a brief summary comparing DSM-5 versus ICD-11. And what DSM-5 essentially did is took the episodes, whether it be a manic, hypomanic, or depressive episode, and added the option of being able to put a specifier with mixed features, and that one can have an episode, an affect or a mood disorder episode with mixed features in either major depressive disorder or within any of the bipolar disorders, bipolar 1, bipolar 2, or the not elsewhere classified. So what ICD-11 proposes is identifying an episode as a mixed hypomania, a mixed mania, or a mixed depression. Both of these, DSM-5 and ICD-11, have taken the somewhat arbitrary approach of requiring 3 or more symptoms of the opposite pole to be considered a mixed episode or an episode with mixed features. However, there is plenty of research that shows just 1 or 2 symptoms of the opposite pole can markedly impact outcome. Next, we're going to talk about some of the evidence, recent evidence for depressive mixed states in particular, and we'll talk about the clinical relevancy of mixicity, especially as it pertains to depressive mixed states or depressive episodes with mixed features. If you recall back to that timeline that we looked at early on in the presentation, you recall that there was a fairly significant gap during most of the middle part of the 20th century where there was very little work done or advances within conceptualization of mixed states, especially depressive mixed states. That has changed markedly over the last 20 to 25 years. And here is a list of just some of the very important papers that have in various ways contributed to our current understanding. I mentioned before, Hagapta Kiskal here in the United States has been a significant thought leader in the US for the concept of mixicity and the broad range of intermediate phenotypes and things that don't fall neatly into either bipolar or unipolar major depressive disorder as characterized by DSM, or at least the earlier DSMs. An important step here in the US was the National Comorbidity Survey study, the replication study, at the beginning of this century, and an important paper by Angst et al., which recognized the quite significant prevalence of subthreshold bipolarity, i.e., subthreshold not meeting hypomania or mania level threshold within the US population, and that depressive episodes, major depression or depressions with subsyndromal or subthreshold hypomanic manic-like symptoms were actually very common, and it had a greater level of morbidity associated with it than pure depressions. This is, I think, was very important because, again, it was a large epidemiologic catchment study, and really, I think, forced those of us here in the United States to recognize both the common prevalence of these things, but to think about their possible relevance. Hence, we saw a lot of work going back to earlier data sets. Lou Judd and colleagues went back to the collaborative study data set, the Psychobiology of Depression collaborative study data set from the 1980s and 90s, looked at that data set, and discovered within that data a lot of very consistent themes that to this day really influence how we think about mixed states. And what you see here is essentially a word salad of clinical features of mixed states, specifically depressive mixed states. And this is an amalgam of much of the many of the references that we just looked at, and the consistency over the last 20-25 years has been startling. And whether it's in US data sets from the 1970s and 80s, whether it's in prospective studies, whether it's in the large Bridge 2 study and a multi-center study in Europe, which is a large international study, regardless of the location, certain themes come up over and over and over. And those include that mixed states tend to occur with significant comorbidities in terms of other psychiatric conditions, substance and alcohol use syndromes, other medical comorbidities. Similarly, certain clinical presentations, including irritability, distractibility, agitation, heightened suicidality, sleep disturbance, heightened arousal. Sometimes it may be considered insomnia, but it's really not just trouble falling asleep. It's a heightened level of alertness at a time when the person should be able to fall asleep. So the brain is overactive. The brain is alert. It's an excited, activated state. And one of the limitations, one of the many limitations of our current DSM-5 criteria is it still utilizes the description of insomnia being decreased need for sleep. And that's unfortunate because that conceptualization, need is a subjective concept. And if you ask someone who is in a mixed state, who's having profound sleep disturbance, they'll say, Doc, I need to sleep. I can't sleep. I'm not able to fall asleep. I'm fatigued, I'm tired, I'm exhausted, but my body won't let me. My brain won't let me fall asleep. And this is a really important distinction because these folks want to sleep. They are tired, but they're unable to sleep. And the other thought, the other concept that goes along with the racing thoughts is sometimes their thoughts are just crowded. They not only have rapid thoughts, but they have a lot of divergent. And as one patient once told me, it's like watching a ticker tape go by, and it's not just one thing or another. And oftentimes we tend to mistake trouble falling asleep, especially if people have a lot of active thoughts at night. We tend to associate that sometimes incorrectly as purely being worry. And certainly if someone's in a dysphoric or depressed mood and they have thought activation, they may be worrying, but their thoughts may jump to 100 different things. They're not ruminating on just one single concept. They're not ruminating, worry about how am I going to pay the rent, or a relationship difficulty, or a family conflict. They're unable to quiet their mind. And so these concepts are really key to understand the phenomenology and how they present somewhat differently within a mixed state. The other clinical features that come up over and over for people with depressive mixed states, they tend to have affective illnesses that start much earlier on, very commonly in adolescence, sometimes even before. In fact, probably at least a good 2/3 of them have onset before the age of 20. They also tend to have a lot more previous suicidality. They have poor treatment response to antidepressants, and oftentimes a family history loaded not only with bipolar illness, but with treatment-resistant depressions, with sort of chronic recurrent affective illness and suicidality. So it's family histories loaded with affective illness, suicidality, all things that we tend to see more often in folks who are at risk of developing mixed states. So we talked about how you recognize the mixed state and some of the features associated with it. But I think it's really important for clinicians to be able to anticipate or identify amongst their patients who might be at risk of developing mixed states in the future. Specifically, since we said that mixed states tend to be associated with poor treatment response, before we start our next treatment, whatever it might be when we're treating a patient, we need to think about what is the potential that they may develop mixicity, what warnings should I give them, how soon should I have them come back, what are the things I need to be monitoring for. So we'll go right down this list here. Obviously, if someone's had mixed episodes in the past, they're more likely to have mixed episodes in the future. Similarly, if they've had any of these symptoms that are any of them alone may not be diagnostic currently as per DSM-5, and there's a lot of debate upon the adequacy of DSM-5 criteria, but the non-specific, but to some degree highly pathognomonic symptoms of agitation, irritability, impulsivity, intractable sleep disruption. It's really heightened arousal at nighttime while trying to sleep. These are all things that if someone's had them in the past, especially if they've had them develop in response to previous antidepressant treatments, that is a significant flag for recognizing the potential for developing those symptoms again with future antidepressant treatments. I should also note that it's possible to see it with certain other somatic, biologically mediated depression treatments, such as light therapy, phototherapy, TMS. It's also been identified with other medications, such as steroids, prednisone, for example. It's been identified with sleep deprivation and significant circadian rhythm disruption. So anytime there's a biologic somatic provocation that has induced any of these symptoms, this should be a flag that this is a person who has a diathesis, who is at risk potentially of developing mixicity in the future. A patient who has come in and reports multiple past intolerances, not just inability to respond or inadequate treatment response, but who reports having really sort of exaggerated adverse events very quickly with antidepressant treatments, or even somewhat paradoxical. Someone who becomes more agitated on a antidepressant that's traditionally thought of as being more pro-somnolent or more sedating. That would be a flag. The other thing that is not considered, unfortunately, within our current criteria, but is very important, and that's to look at the course of a person's treatment in the past, and also the course of their clinical presentations. I mentioned earlier that mixed states are highly protean, they're highly variable. And so a patient who has had clinical presentations of both very sort of classic orthodox depression, especially of atypical depression, someone who had periods of time when they're hypersomnolent, hyperphagic, where they're very psychomotor retarded, perhaps sleep 10 to 12 hours, 14 hours, who also has periods of depression where they're agitated with significant insomnia and edginess and restlessness and agitation. That's a real tip-off that that is a person who is cycling and has had both orthodox pure depressions, that'd be all those across those three Kraepelinian dimensions, all three arrows going down, with some presentation of an admixture of arrows within those three dimensions. That would be very suggestive. Early onset with multiple episodes, so polyepisodic courses, as well as past suicide attempts and parasuicidal behaviors. So not just suicidal behaviors that are self-destructive with intent to end life, but also parasuicidal behaviors, cutting, scratching, head banging, burning. And sometimes these really are not due to a desire to end one's life, but they're due to the overwhelming, agonizing psychic distress that occurs during mixed states. There's a lot of evidence, and in fact, the collaborative study, again, going back to the 70s and 80s, early 90s, demonstrated people are most likely to commit suicide when they're cycling from one state to another, and particularly when they're in mixed states. These are highly distressing, agitated, impulsive type of states when folks are just struggling. And for some people, cutting or burning is an attempt actually to decrease some of the psychic pain. The other thing that we see oftentimes with people who are at risk of developing future mixed states is sort of the presentation of the other comorbidities that oftentimes go along with people who have broadly within the bipolar spectrum and the highly recurrent affective illnesses. So panic-like symptoms in the past, tension-driven compulsive behaviors, ADHD symptoms, especially ADHD symptoms that worsened or did not respond to psychostimulants as kids, episodic alcohol and substance use. For me, it's sort of a giveaway when someone suddenly starts using alcohol, or maybe even more significantly, someone who suddenly starts using cannabis in their 40s or 50s, who was never a heavy cannabis user, for whom that's not something to ordinarily do. But what they're really doing is they're trying to self-medicate the overactivation and the heightened tension that goes along with mixicity. certainly past affective instability, cycling, impulsivity, and as we mentioned before, family history of bipolarity, but also included with that is family history of completed suicide attempts, or just highly recurrent treatment-resistant affective illnesses of any type, whether it be bipolar or unipolar. So we've spent a lot of time talking about how you recognize mixed states, how you maybe anticipate who's at risk of developing one. But we haven't really talked about what's the clinical relevance? Why does it make a difference? Well, for one thing, mixed states are oftentimes underappreciated because here in the United States, at least, it was previously only possible to be considered to have a mixed state if one had bipolar 1 manic mixed state, which essentially required that you have all the necessary criteria both for a manic episode and a depressive episode simultaneously. Most of us were trained in the era before DSM-5, and so unfortunately most of us, most clinicians, really haven't had a chance to understand what mixed states are, and especially the more subtleties, and hence the gross under recognition or misdiagnosis. And oftentimes what ends up happening clinically is people in mixed states tend to simply be labeled as having generalized anxiety disorder or depression with anxiety, sometimes borderline personality disorder or other conditions, but mixed states themselves are significantly under-recognized. They're important because mixed states are associated with significantly increased levels of substance abuse as well as heightened anxiety symptoms. That includes not only panic symptoms, but worsening of PTSD, worsening of OCD symptoms, almost across the board. There's also an association of mixicity with obesity, with binge eating. It's also been more highly associated with certain heightened somatic medical conditions, especially if they're tension driven. So migraines, irritable bowel syndrome, various pain syndromes, all can be worsened from mixed states because of the heightened level of tension. Cardiovascular disease has also been found to be more prevalent in individuals with depressive mixed states. The other very important reason to recognize depressive mixed states is that folks with mixed states are at increased risk of suicide. And this is probably one of the most consistent findings internationally of all the recent studies of mixed states, especially within depressions, is a heightened level of suicidality, whether it be a major depressive disorder or bipolar disorders. And unfortunately, as we've talked about before, the current criteria within DSM-5 still leave us lacking for clinically useful ways to recognize these, because it's trying to shoehorn a diagnosis or a criteria set out of pre-existing criteria that may not be as relevant for ready clinical identification. And hence, much has been written recently. And actually, I will harken back to Dr. Kiskell. Hagerup wrote about these 25 years ago, the importance of recognizing irritability, distractibility, and agitation as very common non-diagnostic but highly suggestive symptoms. When I say non-diagnostic, they are not part of our formal criteria, but in some ways, they're more useful diagnostically than our current DSM-5 criteria. And the other reason, very important reason, to recognize depressive mixed states in terms of clinical relevance is that there's ample evidence that these states tend not to respond to monotherapy antidepressants. In fact, monotherapy antidepressants using a traditional antidepressant alone may actually aggravate and make the course of these affective illnesses more malignant. And hence, the significant importance for us to start to think about alternative ways to approach these conditions. Unfortunately, the FDA has not yet recognized mixed features as within depressive episodes as a target for an indication. And hence, we don't have any FDA indicated treatments yet for treatment of depressive mixed states. However, there have been multiple studies, and that's for a future lecture. There have been multiple studies, and I encourage you to continue to be alert, especially as more and more prospective studies are done to come up with not only appropriate acute treatments, but very importantly, prophylactic or maintenance treatments. How do we actually prevent these from recurring? So I anticipate over the next few decades, we will see much more effort being addressed to the concept of depressive mixed states. If you think about it, Rachel, actually it was not too long ago that we had no treatments indicated at all for bipolar depression. It's a very, as frequent and as prevalent as bipolar depressions are, our treatment field and our regulatory bodies have been very slow to recognize those. And so I think we have to accept that the lack of FDA indication does not indicate lack of effective treatments. It indicates something about where our governmental bodies, our regulatory bodies, and where the field is in terms of identifying appropriate treatments for these conditions. I anticipate over the next couple of decades, we're likely to see much more effort to study and delineate the best management strategies for not only treating acute mixed states, but for preventing depressive mixed states from occurring. And that hopefully will be a future lecture. So, in summary, we've talked quite a bit today about the fact that depressive mixed states are really a very old concept. The idea has been around for over 100 years, evolving largely from Kraepelin's unitary theory of manic depressive insanity and his early conceptualizations of mixed states. And again, talked about the importance of thinking dimensionality, thinking about the dimensions of not only emotion or affect, but also motoric behavior and volition, goal-directed behavior, and the dimension of thought process or level of alertness and arousal. Those three very broad dimensions are really key and remain key to this day to understanding what we currently call mood disorders. The conceptualization and recognition, best way to recognize these is still under really intense debate internationally. And the US does have a ways to catch up. And there's been quite significant written in the last few years, fairly critical of DSM-5 even, that it's really an inadequate compromise. And we need more clinically useful ways that are going to help clinicians recognize this on a day-to-day basis. The other thing that we've talked about is importantly, mixed states are seen not only in bipolar disorder, not just bipolar 1, but bipolar 2, the soft spectrum, but also major depressive disorder if one attempts to look for them. And in fact, they're surprisingly prevalent. While they may be more common in bipolar disorders, it's been estimated that up to 50% of people with bipolar disorders may have mixed states at one time or another. Even within major depressive disorder, the prevalence of mixicity is approximately 30%. That's a fairly good portion. And then when you think about the significance and how much mixicity represents treatment resistance and poor outcomes, you really see the importance of identifying these things. Again, it goes back to the poor prognosis, the much more complicated malignant course with lots of comorbidities, poor treatment outcomes that leads to antidepressants and traditional depression treatments, and sadly the really heightened risk of suicidality when people are in depressive mixed states. And lastly, we've talked about the fact that the optimal way of going about not only identifying but managing these conditions remains still open for further investigation. However, I really must add that almost weekly, certainly every month, I come across another article with new revelations, whether treatment studies or observations going back to older data sets and retrospectively identifying things that weren't recognized before. I really encourage clinicians to be posted. And frankly, if you think about it, by the time most manuscripts get published and what we read in our journals, it's, several years sometimes after the study was actually conducted. So I encourage you to stay posted, be alert to educational opportunities in your communities, and wherever you may access new information as it comes out, conferences. This is something that we cannot wait until the next set of guidelines come out. Guidelines are simply arbitrary consensus agreements, but they're not necessarily the best way to go about things. Evidence-based medicine is only as good as the evidence base. And we have a long ways to go in building this evidence base. So thank you for your listening to this presentation, and I'm going to turn it over to Rachel.
Thank you so much, Dr. Gilmer. You provided some really great insights into this complicated topic. And I just really appreciate your time, your expertise, and all the fun that we had getting this deck put together. So thank you so much. PsyQ community, as always, you can check out the PsyQ website, and then you can see some different options for following PsyQ through our various social media platforms on this slide. And with that being said, we thank you so much for your time and for your attention as we have discussed this important topic, mixicity in depression. What is it, and why is it important for your practice? So thank you so much. Again, Dr. Gilmer, really, really appreciate your time.
And thank you.